Hello everyone. So welcome to the new session. Here I am going to discuss about peripheral nerves and skeletal muscles. Some important short note questions. You won't get any essay type of questions from this chapter. Okay. And so without wasting much of the time, I would like to go with the first topic. A very, fantastic disease or a very commonly encountered disease in your IMC, that is called GBS, so-called Guillain-Barre syndrome. It is actually an acute inflammatory demyelinating polyneuropathy, also called as AIDP. It is actually a demyelinating disease of the peripheral nerves, which may lead to life-threatening respiratory paralysis. Remember, the paralysis is an ascending paralysis. That means distal muscles affected followed by proximal muscles. Histology shows inflammation and demyelination of peripheral nerves and spinal nerve root. If the nerves are involved, we call it as neuropathy. If the nerve roots are involved, we call it radiculopathy. So both are involved. Hence, in GBS, we call it as radiculoneuropathy. What is the pathogenesis? I told it is an immune-mediated demyelinating neuropathy. Here, because of some antigens of Campylobacter jejuni, the most common infection, cytomegalo, Epstein-Barr, Mycoplasma pneumoniae, or any prior vaccination history may present with Guillain-Barre syndrome in the near future. Fine? Okay. So actually, what is the basic pathology here? It is a T-cell immune-mediated response, which is accompanied by segmental demyelination. How this segmental demyelination occurs, the macrophage pathway will be activated. These macrophages will start eating the myelin. Very, very important point. And remember, that is why histology I shows there will be what is the features? There will be inflammation and demyelination of the spinal nerve roots. Coming to the morphology, the dominant finding that you see is inflammation of the peripheral nerves, which you can see as perivenular and endoneurial infiltration by lymphocytes, macrophages, and a few plasma cells. The characteristic type of demyelination you will encounter here is actually called as segmental demyelination, which mainly affect the peripheral nerves, is the most common lesion. Okay, fine. And here, remember, fine. So I told you there will be inflammation of the peripheral nerve, and finally, what will be there? Following that, after that, there will be inflammation of the nerve roots. That is what we call radiculopathy. The clinical picture is absence of deep tendon reflex associated with the ascending paralysis. Remember, sensory involvement, including loss of pain and sensation of will be also there. Nerve conduction velocity will be slowed. Why? Because of the destruction of the myelin segment. And very, very important, a characteristic finding you see in CSF is called CSF, protein levels will be markedly elevated. Okay, CSF protein level will be markedly elevated because of inflammation and altered permeability of the microcirculation within the spinal roots as they traverse the subarachnoid space. Okay, and what is the treatment? As far as the most important treatments are plasmapheresis and intravenous immunoglobulin. Intravenous immunoglobulin is given in very few conditions. One such is Guillain-Barre syndrome. Other one is what we call it as our Kawasaki disease, which mainly affects the children. Okay, all this. So that finishes acute inflammatory and demyelinating polyneuropathy. There is another condition where I would like to mention just an MCQ, that is onion bulb appearance. That is, we can see multiple layers of Schwann cells which are wrapped around. Okay, I will show the picture. You can see this is actually the characteristic onion ring appearance. You can see the various layers of Schwann cells. Okay, this is actually features of chronic inflammatory and demyelinating polyneuropathy. GBS is an acute inflammatory and demyelinating polyneuropathy. Okay, fine? Yes. Then remember, in leprosy or the Hansen's disease, in lepromatous leprosy, there will be more involvement of the nerve, okay, compared to tubercular leprosy. And another important point what I would like to say is varicella zoster virus, which is the most common viral infection of the peripheral nervous system, and shingles, okay, that is commonly called as shingles. Yes. So actually, what do you mean by shingles? That is actually the activation of the latent infection. Okay, that is actually called as shingles. In shingles, remember, there will be always skin eruption in the distribution. Okay, that follows the sensory dermatome. That is one of the characteristic feature of the shingles. Shingles is actually nothing else but a reactivation of the latent varicella zoster virus infection. Fine. And once that is done, next I would like to discuss about diseases of the neuromuscular junction, out of which the most common diseases that you have already studied, that is myasthenia gravis. Okay, I'm going to be crisp and precise in myasthenia gravis because it's a disease that you all know. Fine. So what do you mean by myasthenia gravis? Actually, it is again an autoimmune disease. Number one, autoantibodies are produced against what? Acetylcholine receptors. Fine. So what happens here? The autoantibodies are produced against the postsynaptic acetylcholine receptors. Okay, and what will happen? These anti-acetylcholine receptor antibodies, which leads to aggregation and degradation of the receptors. Okay, as a result, what will happen? The acetylcholine esterase enzyme. Okay, the acetylcholine will not be able to function because it is being degraded. So what will happen? The muscle will not undergo contraction. Okay, fine. So this will limit the ability of the myofibers to respond to acetylcholine. Fine. And another important is activation of the receptor tyrosine kinase pathway and complement pathway that is also being described. Remember, there is a strong association between pathogenic anti-acetylcholine receptor antibodies and thymic abnormality. Remember, thymic hyperplasia is the most common condition, followed by thymoma. Don't run thymoma as the first answer. Thymic hyperplasia is much more common than thymoma. Okay, these are the two important extra. It's a manifestation of our myasthenia gravis. Fine. Then coming into the clinical features, we have anti-acetylcholine receptor antibodies, okay, which will typically present with fluctuating weakness that worsens with exertion and often over the course of the day. Very, very important. Okay, weakness will worsen over the day. Diplopia, ptosis, involvement of extraocular muscles. Okay, and finally, the cause of death is because of the spasm or the failure of the contraction of the respiratory muscle. So finally, the patient will end up in mechanical ventilation. Okay, very, very important. What are the important clinical diagnostic tools we have go for EMS? That is electromyography, nerve conduction studies. Okay, everything can be done. Remember, out of that, most gold standard is electromyography. Fine? Yes. Fine. Then another important condition is called Lambert-Eaton myasthenic syndrome. Just a word about that. It is an autoimmune disorder which is caused by antibody that block the acetylcholine release by inhibiting the presynaptic calcium channel. It is not acetylcholine receptor, it is a presynaptic calcium channel. Just remember that one point. And remember, Clostridium botulinum, okay, which bacteria which produces the Botox, okay, Botox, that will also block the release of acetylcholine from presynaptic neuron. That is why Botox injection is now used for migraine treatment. It is also used for the treatment of dystonia, okay, dystonia. Fine. Once that is done, just important thing, type 1 and type 2 muscle fibers, just few important points that you have to remember for your MCQs. Mitochondria is more in type 1, lipid content, resistance to fatigue is more in type 1. That is, type 1 means sustained force, aerobic exercise. But glycogen content, high oxidative capacity is type 1, whereas high glycolytic capacity is type 2. Mitochondria is low in type 2. Okay, so type 1 has high mitochondria, so it is red in color. Example, soleus muscle. There is pectoral muscles, no, it is type 2. It is having type 2 fibers are less resistant to fatigue. Another important question is inflammatory myopathies, that is dermatomyositis. Again, it is an autoimmune condition mainly present with proximal muscle weakness, and dermato means always involvement of skin is present. Okay, it actually occurs because of damage to the small blood vessels which contributes to the muscle injury. We can see some telangiectasia in the nail fold, eyelids and gums, and biopsies of the muscle and skin will show deposition of the complement membrane attack complex, that is C5b29 within the capillary beds. This is responsible for the pathogenesis. What are the three important antibodies that you have to remember? Number one, anti-MI2 antibody. Okay, that is mainly associated with the clinical manifestation called Gottron papules and heliotrope rash. Gottron papules means you can see this violet hue around the iris. This is called as a heliotrope rash, and similarly you can see some papules in the knuckles. Okay, that is actually called as the Gottron papules. And the Jo1 antibodies, that is actually associated with the mechanic hands. Mechanic hands in the sense the hands will be so rough. And anti-P155, 140 antibodies, they are mainly associated with the paraneoplastic and juvenile cases of dermatomyositis. Just remember two things: anti-MI2 is associated with the Gottron papules and heliotrope rash, and the Jo1 antibodies is associated with the mechanic's hand. So what are the muscle biopsies? Actually, the investigation of choice. Okay, muscle biopsy is the investigation of choice, which will show infiltrates of mononuclear inflammatory cells. Okay, especially perimysium. You know, perimysium, endomysium, and epimysium. Okay, these are three important layers you have to remember. Out of that, there will be perimysial connective tissue infiltration, and there will be perivesicular muscle atrophy will be there, and very important, CD4 plus helper T cells will be extremely high. Okay, there will be infiltration of the CD4 plus helper T lymphocytes. Number 1 point, mononuclear infiltrate. Number 2, perimysial inflammation. Number 3, perivesicular atrophy. Number 4 is CD4 plus T helper cells. So again, muscle weakness will be slow in onset. Which muscles will be affected first? I already told it is a disease of the proximal muscles. And other clinical studies include, so you can go for investigational choice is actually muscle biopsy. We can be, but at the same time we can also go for electrophysiological studies. And remember, heliotrope rash, Gottron papules, and what else? That is mechanic hands. Okay, fine. Remember, in contrast to this dermatomyositis, we have a condition called inclusion body myositis, in which there will be infiltration of CD8 plus T cells, and you can see reddish granular rimming in modified gomorid trichome stain. Just remember this point, okay? Nothing readed. And remember, it is the most common inflammatory myopathy in elder age, that is more than 50 or 65 years. Next condition, what I would like to discuss is actually called as Duchenne muscular dystrophy. What is it? Duchenne muscular dystrophy. Duchenne muscular dystrophy. What are muscular dystrophies? They are inherited disorders of the skeletal muscle, in which there will be progressive muscle weakness, which will manifest mainly during childhood and adulthood. Out of that, the one which needs special mention is actually what we call as the Duchenne muscular dystrophy. Okay, actually an X-linked recessive disorder because of the mutation in the gene protein called dystrophin. You know, dystrophin is actually the largest protein in the body. Fine, yes. And Becker muscular dystrophy is nothing else but a milder variant of a. There is in Duchenne, dystrophin is completely absent. In Becker's, it will be present. Okay, but less function. Duchenne and muscular dystrophy are caused by loss of function between dystrophin gene. Remember, dystrophin is the largest protein located on chromosome number X. What is actually the function of the dystrophin? See, as you can see in this picture, this dystrophin is actually it is actually a mechanical stabilizer. Okay, it is actually a mechanical stabilizer between the myofiber and its cell membrane during the muscle contraction. Okay, fine. So whenever there is a dysfunction, what will happen? The muscle will undergo dystrophy. And very, very important point, it is mainly associated these mutations, the most commonly are deletion and frame shift type of mutations. Okay, fine. And in addition to this stabilizing function, it also have another function in the signaling pathway. For example, it interacts with the nitric oxide synthase. You know, nitric oxide is a relaxant. So what are the basic morphology? In morphology, you can see the dystrophy of the muscles. Okay, there will be a dystrophy of the muscle, and muscle biopsy is the investigation of choice. And here, remember, the muscle biopsy will show segmental myofiber degeneration. Myofibers will undergo atrophy. Remember, there is no inflammation. There will be fatty replacement or fatty infiltration. That is why there will be something called as a pseudo hypertrophy of the calf muscles. Even though there is dystrophy, there will be pseudo hypertrophy. Actually, the pseudo hypertrophy is not because of the hypertrophy of the muscle fibers. It is actually because of the fatty infiltration that is responsible for producing hypertrophy. Since it is not the real hypertrophy or the true hypertrophy, and it is just because of the fatty infiltration, we call it as a pseudo hypertrophy. Fine, okay. And remember, there will be absence of dystrophin in IHC staining in case of Duchenne muscular dystrophy, whereas in case of Becker muscular dystrophy, there will be reduced staining. And a characteristic and important clinical feature that is you will see Gover's sign. What is that? Gover's sign. Okay, that is the child when he get up, he will actually rise, he will actually crawl on himself. Okay, fine. There will be weakness of the pelvic girdle muscles, there will be weakness of the shoulder girdle muscles, and remember, there will be death by age of 10 or 13 years, and this is mainly because of worsening respiratory reserve and sleep hypoventilation, whereas the death will be around the age of 30 or 35 years, okay, more life expectancy in case of Becker's muscular dystrophy. Fine. And Duchenne muscular dystrophy, there will be respiratory insufficiency, pulmonary infection, and heart failure. Okay. Gene therapy is actually being on. Already we have a lot of gene therapy modalities for Duchenne muscular dystrophy. Just remember, myotonic dystrophy, it is autosomal dominant. Okay, it is autosomal dominant. There will be muscle weakness, cataract, endocrinopathy, and cardiomyopathy, and there will be congenital myotonia. The problem here is it is actually trinucleotide repeat disease, like our Fragile X syndrome, like our Huntington's disease. Here it is CTG triplets. What is it? It is CTG. Just remember CTG. Coming into mitochondrial myopathies. What are mitochondrial myopathies? These are mitochondrially inherited diseases that mainly going to affect the muscles. Okay, remember, muscles, we have what we call as adenosine triphosphate ATP, which is very, very important for the contraction of the muscle. Because of this mitochondrial mutations, mitochondrial DNA is very high chance of undergoing mutation than our normal DNA. So what will happen? There will be weakness of the muscles. There will be involvement of the extraocular muscle fibers, and that is CPEO, chronic progressive external ophthalmoplegia. That is actually one of the mitochondrial diseases. Okay, it is actually one of the mitochondrial diseases. And the most important, okay, mitochondrial myopathies are very rarely asked as a short-term question. Just for MCQ purpose, what you have to remember here is we can see something called as ragged red fibers. What is it? Ragged red fibers. Okay, ragged red fibers. And immunohistochemically, IHC staining shows reduced staining for cytochrome oxidase. Remember, mitochondrial DNA is only maternally inherited. Only maternally inherited. What are the mitochondrial diseases that you have to remember? One is called MELAS. What is MELAS? Mitochondrial encephalopathy, lactic acidosis, and stroke-like episodes. Number 2 is Guillain-Barre syndrome. Okay, what is that? Guillain-Barre syndrome. Number 3 is myoclonic epilepsy with ragged red fibers. Number 4, Leber's hereditary optic neuropathy. Number 5 is a necrotizing encephalopathy called as Lake syndrome. Just remember what all are the names of the mitochondrial myopathies. Mitochondrial diseases, not myopathies, mitochondrial diseases. Fine? Okay. Coming into the next most important question, that is schwannomas. It is actually a peripheral nerve sheath tumors. What do you mean by schwannomas? It is a benign tumor. Another one tumor is neurofibroma. Again, I am going to describe both simultaneously. Schwannoma is a benign tumor. Neurofibromas are a benign tumor. Schwannoma, it mainly arises from the Schwann cells. Okay, Schwann cells are responsible in the peripheral nervous system. Okay, they are responsible for the myelin sheath generation in the peripheral nervous system. In the CNS, we have the oligodendrocytes. Neurofibromas, again, they mainly arises from the nerve sheath. Okay, fine. And schwannomas are mere a component of neurofibromatosis 2. So what do you mean by so I will say about neurofibromatosis 1 and 2 a bit later. Remember, schwannomas are a component of neurofibromatosis 2. Remember, the neurofibromin 2 gene on chromosome number 22, it codes for a protein called merlin. Okay, it codes for a protein called merlin, which is mainly responsible in cell signaling pathway, which mainly helps in controlling the shape of the cell, growth of the cell, attachment of the cells, that is cell adhesion. So just the morphology of the schwannoma is the one which we have to remember. Actually, in gross we have well circumscribed encapsulated masses, which are loosely attached to the nerves without invasion. If the invasion is present, it is malignant. Okay, so schwannomas are benign tumors, I have told. So grossly they form firm grey masses. Microscopically, we have two important findings, that is called antennae A, antennae B areas. Antennae A means they are hypercellular areas. Okay, they are hypercellular areas, whereas antennae B is actually a loose and a hypercellular areas, hypocellular area. Remember, in antennae A, we can see some ramification. Okay, there will be palisading of, see, you can see in this picture, no, there is a palisading. Okay, this is antennae A and this is antennae B. Okay, you can see palisading of the nucleus. This palisading of nucleus you see in schwannomas is actually called as Verroque bodies. Verroque bodies, very, very important. This is a university exam spotter for your pathology practical exam. Fine? Okay. And antennae B bodies, we can see myxoid extracellular matrix. They are hypocellular. Only we have myxoid deposition. Fine. Electron microscopy, you can see basement membrane deposit encasing the single cells and the collagen fibers. And remember, what is the IHC marker for schwannoma? It is S100. It is this S100 which is the IHC marker for malignant melanoma also. Fine. So there will be acoustic neuroma. Fine, and these schwannomas may also arise at the cerebellopontine angle at the origin of the vestibular branch of the 8th cranial nerve. Neurofibromas are benign nerve sheath tumors. Remember, there will be not only Schwann cells are undergoing proliferation, there will be fibroblast, mast cells, and CD34 plus spindle cells also undergo proliferation. We have three different types. You have to remember superficial cutaneous neurofibromas, which occur oftenly clinically present as a pedunculated nodule, and diffuse neuromas, which are large plaque-like elevation of the skull, which is mainly associated with neurofibromatosis type 1 specifically, and plexiform neurofibroma. Okay, plexiform neurofibromatosis has been it's a question which has been asked in a PG entrance exam question recently. Only the Schwann cells in fibroma show complete loss of, so neurofibromin 1 and neurofibromin 2. Just remember, neurofibromin 1 gene is chromosome number 11, which codes for a protein called neurofibromin, and neurofibromatosis type 2 chromosome number 22 codes for a protein called merlin. So both is involved in cell signaling pathway, which that is receptor tyrosine kinase or KIT receptor tyrosine kinase pathway, which is responsible for cell growth, differentiation, and cell adhesion. So you can see nodular lesions grossly, and remember, what is the histopathology? There will be proliferation of mast cells, perineural cell, CD34 spindle cells. And remember, a very, very important question in diffuse neurofibroma. Okay, this is a feature which is seen in case of localized cutaneous neurofibroma. The second variety is the diffuse neurofibroma, and the third variety is the plexiform neurofibroma. In the diffuse neurofibroma, actually, we have an important finding called pseudo-Meissner corpuscle or tactile-like bodies. Okay, that is there will be focal collection of the cell which actually mimics the Meissner's corpuscles. You know, we have the Meissner's corpuscles, which are the receptors. Am I right? Yes. And plexiform neurofibroma, there will be multiple nerve vesicles and which are commonly referred as the bag of worms appearance. Remember, pseudo-mesener corpuscles or tactile-like bodies are seen in diffuse neurofibroma, and in plexiform neurofibroma, we have something called as the bag of worms appearance. Okay, fine. So these are the important questions. Again, see, remember, neurofibromatosis type 2, it is type 1 is an autosomal dominant disorder. Okay, sorry, I told it is chromosome number 11. Sorry, chromosome number 11, it is actually chromosome number 17. Okay, a correction, I'm just correcting myself. Sorry, it is chromosome number 17 and 2 is chromosome number 22. Okay, chromosome number 17, there is a loss of function mutation, Lish nodules, capilloid spots, okay, are seen. And this, remember, this NF1 protein has a GTPase activity. NF2 is actually 22 codes for the protein called Merlin associated with acoustic neuroma, schwannomas. Okay, fine. So in this we have discussed GBS, which is a very important question you have to read. Myasthenia gravis you have to read. Next is Duchenne muscular dystrophy. Duchenne muscular dystrophy you have to read. Then remember the names like MELAS. Okay, MELAS is most commonly asked. And next is schwannoma and neurofibroma. Okay, both are important. At least you have to read, if not the rest of these things. Okay, just this dermatomyositis are not that much important, but GBS is important. GBS is also very less important. But if you ask me like what is a must-read question, means you should read myasthenia gravis and Duchenne muscular dystrophy. Schwannoma and neurofibromatosis, at least for MCQ or for a university spot. Thank you.